Well, good morning, everybody. So I think I've just been asked to sort of set the scene, which was a very open invitation. So I wasn't quite sure what I was going to talk about, but I'm going to just try and talk a little bit about universal health coverage. And I think most of us are very familiar with it, so I'm not going to spend very long on that. But, you know, where are we at and what are the issues and challenges? What do we know and what do we semi-know and what do we still need to understand better in relation to UHC? And I'm going to deviate in the middle to talk a little bit about health financing strategies, partly because we've been working on a few recently, so I think it's just interesting to think about what they can do and can't do and how. And then I was going to wrap up really with the objectives for the day and the seminar series, but I think Thomas has more or less covered that. But we'd be interested, I think, also in any suggestions of other topics which maybe we've left off, but which you would find useful. So that's me, and we're starting a bit late, but I think I'm going to be about 15 minutes. Okay, so I think everybody is familiar with UHC, and the first thing to say about it is that it is very much embedded now in the global health agenda. So it's pretty much accepted as something we should be working towards, and so the focus is now around the how. It's obviously a hugely ambitious vision. So the aim is to offer the whole package of services to the whole population as far as possible with no catastrophic payments involved and with a decent quality of care. And that is that's quite a high goal for many health systems. The other point to make that's just when we start thinking about it is obviously this isn't one cube. You have a lot of different services, and at the moment the entitlements and the actual availability and reach of them varies according to different service packages and different population groups. In some countries, for example, we've just been involved in evaluation of the free healthcare in Sierra Leone. There, the country was extending entitlements to a certain population group, but obviously not to the whole population for pragmatic reasons around affordability and so on. So it's not one cube, it's a multiplicity of cubes for different services in practice and different population groups. And then there's the fourth dimension, which is time. So the question is not just what can you offer, but how can you sustain it over time? And that's something we also have to think about in our health financing strategies. So just to state the fairly obvious, it is quite a broad definition. There's a lot of interpretation that is needed around terms like appropriate and affordable. And then the key question is how do you operationalize it? And particularly, how do you deal with trade-offs between different groups? And so there has been some thinking about this. But what we are trying to understand is a whole set of not just what inputs are needed, but the whole relationship between those and different aspects of service outputs. So as I said, quality, of course, not just utilization, looking at effective coverage, trying to juggle the different end goals, which is to improve health, but also we want responsive services, we want financial risk protection. Sometimes we have to make choices between them. They don't always go in tandem. And of course, underlying that, we're also having to think very much about equity. And that was one of the initial critiques of the kind of WHO cube, was it assumed that any extension to any group was kind of equal. So it was a volume issue, rather than focusing on which groups were being extended to and was there a prioritization within them. So the equity dimension wasn't very strong initially and is now sort of being added in the thinking. So one report coming out of WHO tried to think about how do we sequence our progress towards UHC, and what are the kind of choices we should be making, and also what are the ones that we shouldn't be making. So the idea was to prioritize services into a priority class, and that was linked to three main criteria, so cost effectiveness, a kind of equity dimension, and then financial risk protection. To expand the high priority services first for everyone, but also ensuring that disadvantaged groups were not left behind. So that's a kind of roadmap of sorts, but when we start to think about operationalizing it in countries, it gets slightly more complicated. So they also laid out what they called unacceptable trade-offs. And I think most of these are fairly intuitive, but they are debatable. So my question is there really a consensus on these being unacceptable? So the first idea was that you shouldn't expand coverage for low or medium priority services until you've dealt with your high priority ones, which is fairly obvious. Secondly, you should give priority, you shouldn't be giving high priority to very costly services which have substantial financial protection. So basically, that doesn't override the health gains, so when health gains are low. Now, again, that seems fairly obvious, but when we think about services, for example, like caesareans, so I was recently involved in evaluating free caesarean policies in various West African countries. I mean, that was a good example of something which was a high priority service. It's supposed to be part of the package of continuum of care. It is costly, but at the same time, the health gains are fairly modest because there's a limited, mortality linked to them, limited number of people, and also because of the way services are utilised, the benefits tend to go to the better off households. So it's a good example of something where, what do you say when you're evaluating that as a recommendation? It's quite problematic. It's certainly, you wouldn't want to recommend that you don't extend coverage for caesareans because they are a life-saving intervention for a core population group of pregnant women. But at the same time, there were equity issues around it, and to some extent, the health gains were quite modest. So often you're making these slightly problematic priority setting decisions. Okay, so the third one, you shouldn't expand coverage for well-off groups before doing so for less well-off. And linked to that, the idea of not expanding to those with an ability to pay over the poor and the informal sector. And again, while those look fair enough, we all know lots of countries where precisely that has happened, and it's happened for pragmatic and also political economy reasons and so on. And was that wrong? Was that wrong if it was part of, perhaps a longer term plan which then did extend, as in Thailand or whatever, to the informal sector and so on? So some of these look as if they're clear cut, but I think there is still quite a lot of debate. And the final one is around making sure that your financing sources are progressive. So even if you're shifting towards mandatory prepayment, if your financing sources for that are regressive, then that's not necessarily an improvement. Okay. So that's just some things we need to think about as we move on the road. So what do we know? We do know that public finance is important to achieving universal health coverage. I don't think there's much debate about that. We also know that we want to move towards mandatory prepayment systems and indeed to reduce fragmentation of risk pools. And again, I don't think there's a huge debate on either of those. We want to reduce out-of-pocket payments. And it's interesting, I don't think you can necessarily see it very well on the screen, but it's in the briefing note that you've got in your packs. It is interesting just to look at some of the recent trends on that. And to see that, so this on the graph is out of pocket for low middle income countries, out of total health expenditure. And you can see that for many of the income groups, there hasn't been a very substantial progress over the last, I think this is since 2000. Can't read my own slide here. But on the pleasing front, the low income group, which is the green line, has shown quite a marked decline since, is it 2000? I can't even read it myself. So overall, there's been a small decrease, but the low income countries are kind of converging a little bit towards the mean, if you like. So those, I think, are some areas where there is a consensus. I think there are then some aspects where we've got kind of international guidelines, but there's less consensus about how useful they are or how we use them. So we aim to bring out-of-pocket expenditure below 20% of total health expenditure. And that's following guidelines from the World Health Organization Health Financing Report. And that's, I think, more or less accepted as being a reasonable benchmark. We've got the Abuja commitment, which relates to proportion of government spending that goes to health, which is less accepted and is seen a bit more as a kind of an advocacy tool to some extent. Then we also have attempts to cost what should be required in absolute terms to provide a kind of basic package of healthcare. So I've put on here, there have been a series of reports that have done estimates, but one of the most recent ones was the one done by McIntyre and Mahias, which came up with two options, both an absolute figure and a proportion of GDP. And there's more debate about those. Clearly, an absolute figure is going to vary by country, but as a sort of general benchmark, it's quite useful to have that estimate. I think it is interesting, though, to see how few countries have reached that, particularly in the low-income group, so the bottom graph there. For the proportion of GDP, equally, it's very much focused on the middle-income countries. So those benchmarks we're nowhere near reaching them for most low middle-income countries as a group. So clearly, there has to be strategizing at the national level around what the barriers are and what the appropriate direction of travel and how do we operationalize these very high-level, ambitious, broad concepts. And one way of doing that is through developing national health financing strategies, and lots of countries have been working on these. And I think it's interesting to reflect on some of the initial experiences, just in terms of both how they've been produced and how useful they have or haven't been. And there hasn't been so much written on that as yet. So just very briefly, what is it meant to be? I think the interesting thing about them is that they are, or should be, kind of problem-based. So they should be looking at the health system as a whole, and they should be looking at where the system is at now, because clearly we don't design health systems from scratch. We're working with a given set of institutions, and really the question is, what is our theory about what isn't working, how it could be changed? So you have to develop basically a set of hypotheses that can be tested. If we tweaked it this way, would it improve this indicator that we're worried about? And then you have to try it and you have to monitor it. So it has to be a sort of iterative process. So essentially, within the health financing strategy, we're keeping our focus on what the ultimate goals of universal health coverage are. We're trying to think about what are the routes through to that, what are the intermediate objectives we need to meet, and how do the health financing functions feed into improvements or indeed deterioration in any of those. So thinking around revenue collecting, pooling, purchasing, benefits packages, and so on, and the links with the rest of the health system. So the key thing when we think about the objectives in our health financing strategy is not just what are the problems, but also which ones are amenable to action. Because clearly there are certain givens which are very hard to change. There's no point setting objectives around something that is politically impossible, for example. So normally you would start with a situation analysis, that's a kind of understanding of the data, understanding of the issues, and then, as I said, trying to identify out of that what are the objectives that we can actually tackle. And so just to give some examples in relation to resource mobilization, commonly we're thinking about how do we deepen existing revenue-raising strategies which are working well. What new ones can we introduce? And we'll be talking a little bit about innovative financing through today, because obviously that's one of the areas where we've been doing quite a lot of work as a group. And indeed, there's been a lot of interest, and perhaps an over-optimistic interest in that area. Which are the ones which are not performing well and we want to put a downward pressure on or reduce or diminish? And of course, how can we improve the quality? Because a lot of the resource mobilization issues are actually not so much about volume, they're more about the quality of the sources, the harmonization, etc., the alignment, which in theory is all agreed on, in practice is often done very badly. So those are some objectives you might pick out. In terms of risk pooling, clearly there is a consensus to moving towards either bigger pools or at least interconnected risk pools, therefore more stable, more sustainable. Looking at whether you're your major vulnerable groups are covered, ensuring that your risk pooling is viable and sustainable. And clearly there are different strategies for doing that, but this is just to give you some examples of the kinds of things that go into a health financing strategy. And as you can see, quite a lot of different options here for purchasing. We are going to be talking about costing. Obviously, one of the key functions of that is also to help us define our benefits package, which is one of the aspects that commonly needs to be remodeled in some way. Changes in provider payments, etc. And not to neglect the way in which health financing system is also governed and managed. And we talked a bit yesterday, we had a session on fiscal space analysis, and one of the questions there was, well, one of the observations was that public financial management is often a bit of a black box. It's something we know matters, but we sometimes don't address that adequately in our planning and national strategies. So do there need to be changes to the governance, to the organisational forms, transparency, but also how resources are managed and accounted for? And finally, we clearly need to think about the prioritisation within those objectives and sequencing. Sequencing is often the hardest bit. And what needs to be in place to make it happen? So capacity building actions, thinking about, obviously, milestones and supplementary measures like communication strategies or often much more detailed implementation plans which go with the strategy. And that's kind of where we're coming to in some of the countries now, like Ethiopia. So Nuri and I were involved in the health financing strategy in Ethiopia last year, and they're now working up to the implementation plan, which is going to be even more exciting and challenging. Okay, so within this whole broad and very ambitious agenda, what are the areas where we need to, I think a bit more and develop our tools a bit more? And I think this feeds very much into the discussion today. So the first is around the costing of the package of care. And I think one of the issues there is that we do, I think, need something a bit more dynamic. And I'm hoping Tim's going to talk to dynamism. Because often we're doing these costings in a sort of one-off static way, and then immediately we're launching into a series of changes which are part of our national health financing strategy, which are going to change our cost structures. So we're already outdating our work almost before we've started. So how do we get models that people can really work with and which can move with the changing times? The whole area of innovative financing, I think we'll be coming back to, but as highlighted in the note that you've got today, the work that's been done, certainly with OPM, suggests that we should be quite modest in our expectations of these sources. So the real gains are going to come from other areas, and I think that we'll highlight that in the fiscal space discussion. We know, and we constantly model efficiency savings, but how well have we ever tracked implementing them and in seeing what money is saved? And so I think there's a number of challenges there. Firstly, really operationalizing efficiency savings. Secondly, monitoring and evaluating them at a systems level, which is relatively rare. And the third aspect, I think, is just understanding a bit more the political economy of it, because health systems that don't retain savings don't have much incentive to make any savings. So I think that's one thing we can maybe come back to in our discussion. I think there's also a recognition that health systems and health sectors, and I don't know whether SAS would disagree with this, but often struggle with negotiating with finance. And so how do we empower the sector? What tools can we use to help the health sector argue its case effectively, but also generate value for money evidence, because that's often part of the trade-off with finance, that they want to see evidence of that. And are we good at, how do we show that evidence? I think within the technical assistance, and indeed within the whole reform process, there's a huge amount of politics. How good are we at negotiating those politics? And we've all, I think, all been in situations where you get wildly different recommendations coming from different advisory groups, for example, to ministries. And how do we manage that? And I think it's also interesting to come back to the first generation of health financing strategies and understand whether they were used and how we can improve them based on that experience. Have they actually changed the world? To paraphrase Marx. Okay. So the objectives for today are pretty much as Thomas already outlined. We want to learn from practical experiences, not only ours, but also yours. We want to understand what advances have been made in respect to some of these tools and what more do we need to do. And I think we're also open to suggestions on other topics for future seminars. So there's some ideas up here which build very much on the work that OPM's been doing. But if there's some other burning topics that you'd be interested in where we can respond, please bring that into the discussion.